Great pleasure to introduce Dr. David Chan. David's been associated with Sydney Vital for quite some time in various roles and capacities, and he's going to give us a talk today about neuroendocrine tumours, a tale of two cancers. Thanks, David. He's then going to moderate the session.
Thanks very much, Dale. I was just going to share a little bit about neuroendocrine tumours. I don't know whether any of you noticed, but you know how there was that excellent presentation at the start with the protein analysis, and there were like about 25 tumour streams? I was trying really hard, and I do this anytime there's one of those big genomic analyses, and is neuroendocrine tumours there? And it wasn't, but don't worry. You know, that's why we've got it covered with multiple presentations of neuroendocrine tumours during this session. And hopefully, you know, I think most people here have heard about neuroendocrine tumours. They're relatively uncommon. We are knowing more and more about them, and it's really hard to do research in an uncommon tumour. So I thought I'd just sort of share a little bit about my journey over the last few years, some of the things we're involved in and how to take this forward over the coming years. And thank you very much to the committee for the invitation to speak. So, my son's 5, and he likes playing a game called Goodies and Baddies. And I don't know whether you can guess, but I'm always the bad guy being chased around. And inevitably I get something thrown at me or I get jumped on. And I feel like this is a little bit like that. So I wanted to start with the two countries we talked about, and then I wanted to talk about two different types of neuroendocrine tumours, because I think a lot of my research has been looking at, well, how do you tell the difference between aggressive neuroendocrine tumours, the ones that actually kill you, and the ones you read about in textbooks, which are the benign ones that generally have an indolent course. I trained here towards the end of my medical oncology training. I was also the neuroendocrine fellow supported by Sydney Vital. Started my PhD at that stage, and then I went and did a fellowship overseas in Toronto. And then during that time, I continued my part-time PhD candidature. And when I came back, that's thankfully finished. And currently I'm holding a grant to continue the same kind of research looking at quantitative imaging analysis, particularly of PET analysis in neuroendocrine tumours. So some flavour slides. On the left, this is poutine. I don't know how many of you have had it. It's pretty nice, actually. I wouldn't say it's an acquired taste. So cheese curds, gravy. It's perfect for not a hot summer's day, but when it's the middle of December, the temperature's -20, then actually it hits the spot quite well. So this was the hospital that I was at, Sunnybrook, and it looks quite nice in winter, except you have to take care not to slip and slide as I do. So I guess I'm not going to talk about who the goodie and baddie is, because that would really consume the entirety of my 15-minute talk. But I guess I see people with what we call good neuroendocrine tumours, right? The indolent type. And for them, actually, they're unhappy. And their unhappiness is a different one to the high-grade neuroendocrine carcinomas. So people with low-grade neuroendocrine tumours, a lot of them make serotonin, not all of them, probably about a quarter, a third have symptoms. And their complaints are, well, this isn't killing me, but my quality of life is horrible. I have to go to the bathroom 5 times, 10 times a day. I have urgency, so when I want to go, I need to go straight away. And they're mapping out toilets in Westfields, where's my closest escape route, sort of like when we're toilet training. And this reversion, this lack of ability, is really disabling to patients, you know, even though the disease isn't growing. And on the other side, you have the bombastic high-grade neuroendocrine carcinomas, and those are ones that have poor prognosis. Classically, you treat them with chemotherapy. It works for a little while for about half the patients, and then it stops working. And those tend to have a poor prognosis no matter what you do. They don't produce the vasoactive hormone, so you could say, well, you know, at least you don't have carcinoid syndrome. But unfortunately for those patients, high-grade patients, the median survival is somewhere between 12 and 18 months, even with all the advances that we've had in the last few years. And we would usually not do surgery for those patients, whereas for the patients with slower disease, we would do surgery for those patients. And there's a little bit of a suggestion that those patients live longer if you operate on the primary, because the small bowel primary is another part of this disabling feature that we're talking about. People with small bowel primaries often get fibrosis in the area, and then you can imagine that the small bowel curves around and you get a lot of small bowel obstructions, and that can be deleterious to quality of life as well. What I did want to draw your attention to is the PET scan images, and we'll talk about that in the next slide. But just in honor of the pathologist we have in attendance, this is my cursory nod to neuroendocrine pathology. So you can see on the left-hand side, there's a relatively well-differentiated neuroendocrine tumor. And the ways you can see that is looking at the cells, all the cells look kind of the same size. They all look kind of round, and you can see that there's not an abundance of mitotic figures or other things that illustrate a high-grade tumor. On the right-hand side, however, is a high-grade neuroendocrine carcinoma. So this is a grade 3, but a poorly differentiated grade 3. And you can see, even without doing all the stains, which are important in grading neuroendocrine tumors, that tumor looks nasty. Some of the cells are small, some of them are large, all of them are bizarre. They all have a lot of mitotic figures, and that would be one that, augurs a poor prognosis. And so we know that grade changes in patients. We know that some of them have high-grade disease, but actually they started as low-grade, and over time they were stable, and then whoops, high-grade, rapid progression. Other people, they stay low-grade over time, but the way we get grade is we just put a needle in somewhere and we look at the histology and we ask the pathologist, but what if we got the wrong parts? What if we had a sampling error? Some of the tissue is grade 3, high grade, some of it's grade 1, and we're actually giving grade 1 therapy, but the patient's high grade, and we missed out on the opportunity to give good therapy in the first place. So on the left, we can't take credit for this. This was from the PNMAC group. We have a privilege of having 2 different PET scans to image neuroendocrine tumors. We talked about the low-grade neuroendocrine tumors, and as you've heard from Sharon's excellent talk before, these express somatostatin receptors. And so if you use somatostatin receptor targeted PET scan, they should be positive on that. So good neuroendocrine tumors should light up on the dotatate PET scan. And if you look at FDG PET scan, which is the normal PET scan we think about in cancer biology, that reflects glycolysis or increased metabolic activity. So high-grade neuroendocrine tumors should grow quickly, use up lots of sugar, and therefore be positive on that scan. So this is a schema, but you can see that grade 1 tumors should be expected to be positive on the dotatate PET scan, and grade 3 tumors should be positive on the FDG PET scan, with tumors in the middle being some intermediate mix of those. And so you can see that, well, there's a patient on the right-hand side. You can see that the dotatate PET scan shows multiple metastases in the liver there, whereas the FDG PET scan is fairly inconsequential. There's not much uptake in that area. So I think probably more than half the people in this room have heard the slide before, so I apologize, but we'll go through it because I think it's important to look at the next steps from here. So one of the studies did during the PhD studies was a retrospective analysis of 62 patients with advanced neuroendocrine tumor of any primary. These patients had to have dual PET scans, both dotatate and FDG PET scan, within 31 days of each other, across different grades, as you can see from the table, as well as across different primaries. And we developed a scale from 1 to 5. We've called it the NetPET score, and part of the reason was because PetNet was a registered company and we didn't want to infringe copyright. So 1 is, patients who have just uptake on the good scan. 5 is patients who have lesions that uptake on the bad scan but not the good scan, and 2 to 4 somewhere in the middle. And those were the 3 groups that we sort of allocated to say, well, maybe the people with the nice imaging features are low grade, the people with the nasty imaging features are high grade, and intermediate are somewhere in the middle. So this was the original study that we published in 2017. And you can see that the 3 separations there using the score separated patients in terms of overall survival and was significant in univariate and multivariate analysis. It also correlated with histological grade, which was, as per, I guess, the hypothesis. And the overall survival remained significant on long-term follow-up, although, as you can see from the sudden decrease in the top curve, these are relatively small numbers that need to be validated. So I guess the impact of what we did was we said, I think even about 3-4 years ago, and in some places across the world, people said, well, we should use one PET scan or another PET scan. For low-grade tumors, we should just use the dotatate PET scan, the good PET scan. And for high-grade tumors, we should just use the FDG PET scan. And I think what we're suggesting is, well, you guys think we know what we're talking about, but actually sometimes we don't. Maybe we had sampling error, as we talked about. Maybe there's grade transformation. It started as low-grade, but it became high-grade. And so we're suggesting that I think we should use increasing amounts of dual PET scanning with the purpose that it illustrates areas of high-grade tumor. So I guess this is a patient of Nick's who initially had a low-grade neuroendocrine tumor, and you can see those spots on the dotatate PET scan. They're pretty avid. And on the top left there, I think you can see my cursor, can't you? There's uptake in the liver in multiple points, and there was actually a resection of the pancreas which showed a low-grade neuroendocrine tumor. And if you remember, the DOTATATE PET scan is the good one, so you would expect it to uptake there. But after some subsequent treatment, including lutate and another 2 years of follow-up, she developed significant uptake in the FDG PET scan. So you can see that it's still bright on the good PET scan, the DOTATATE PET scan, but you can see that there's significant avidity in the FDG PET scan, corresponding to grade 3 histology, which was high-grade histology when she went for an operation. I can't remember, was it imitation is the highest form of flattery. So a few other institutions, after seeing our publications, tried to replicate this with success, and the most important part of any collaboration is having tapas together. So one of the wonderful things about doing neuroendocrine research is most of the conferences are in Barcelona. So that's Amy Hayes on the left, who's one of our fellows. Are we auto-changing the slides or not? No? Okay, that's very strange. Never mind. We are trying to extend the findings in a couple of ways. So firstly, there were only 4 to 5 patients with lung neuroendocrine tumours in the original study. And we know that these tumours behave differently, they're classified differently, and they have genetic differences compared to GI and pancreas neuroendocrine tumours. So we did a multi-centre study with Memorial as well as Royal Brisbane, and we found similar findings in 38 patients. Again, with this score, the 3-tier system remaining significant in predicting for overall survival and also high grade of histology. And we should get that into a major journal in the next couple of weeks. The second analysis is a quantitative analysis of gut neuroendocrine tumours. So currently we have been visually comparing the uptake on the 2 scans, but we're going to try and refine that with the largest sample size. So we've got, I think, about 200 patients, which is a fairly large cohort for neuroendocrine tumours, with preliminary data collected, submitted to a conference, and hopefully with a manuscript at the end of next year. And I think that's the theme of today, isn't it? Which is, I think, hearing from the previous speakers, collaboration is so important, and having multiple institutions come together to pull data, to build these friendships. I mean, partly it gives you things to do and people to enjoy eating tapas with, but partly this is the way I think we will drive research in rare tumours. A second project that we did during my PhD candidature, just to talk about some of the imaging-related things, is a semi-automated FDG PET analysis in neuroendocrine neoplasms. So you can see that this is one of our patients who had a metastatic grade 3 neuroendocrine tumour. And can you see that there's lots and lots of areas of uptake on the FDG PET scan, and they're all tumour. And what people used to do was draw around one and then say, well, is this bright or not? But we know that it's not just about how bright it is or whether there's brightness, but conceptually, if you think that there's more places with this aggressive disease, more volume of uptake, well, that would be an issue, wouldn't it? Because then you've got large amounts of aggressive tumour. No one, I think, prior to us had done this work because people found it reasonably time-consuming to draw circles around every single one of these lesions. And this patient had 49 contours. So you can imagine you would have had to write 50 spheres and then shrink it down manually and verify each one of them. So we created auto-segmentation software, which had a flat SUV cutoff. We involved the nuclear medicine physicians to remove areas of false positive uptake, and then we calculated the quantitative metrics based on that, and we demonstrated that metabolic tumour volume, so the amount of volume that was positive on the FDG PET scan, was significant for prognosis. So you can see that the black line there is our cohort of 190 patients, and that was the overall survival. So you can see it's about 5 or 6 years, and you know that's pretty good across all comers, but still some people do die from this disease. However, if you have metabolic tumour volume that's more than the median, so more than sort of a tiny skerrick of uptake, 5 mils is not much, then the overall survival decreases to 30 months compared to not reached for patients who had less FDG uptake. This was also significant on sensitivity analyses, and as you can see on the right-hand side, this looked at multiple sites. I'm not going to bore you with the multivariate analysis, but only to say that, well, obviously, as the higher grade the tumour, the more uptake you have. So things we'd like to do in the next few years, if time allows, is number one, does this algorithm save time? So if we run things through a computer to do all the really boring bits of putting circles around things that are bright, and then get a physician to say, yes, that's correct, or no, that's not correct, well, you should have the same kind of accuracy. But, you know, how much time does it save? Is this helpful from a health resource utilization point of view? Secondly, we'd really like to validate these results in another cohort study, so building those bridges beforehand will allow us to do that. And thirdly, we know that having uptake, a high amount of tumour volume on the dotatate PET scan is a poor prognosis factor. But what about uptake in aggressive tumours in the FDG PET scan? So I think we need to formally compare these two things to see which one is the more deterministic in terms of overall survival. Some other things we're doing, I'm really excited to be part of a large group. Nick, who's sitting in the front, is in the process of finishing presentations for a large multinational, multi-center study called ControlNet, adding chemotherapy to PRRT. In-house, we've just finished accrual for a study called Donut, because I like sweet food, so thank you very much to whoever catered during the break. Looking at a donut-like appearance on the dotatate PET scan, happy to tell you more about that, but time doesn't allow us today. We've recently presented on immunotherapy and neuroendocrine tumours. It doesn't work yet. We're trying to make it work, unfortunately. Doing some guidelines from a multidisciplinary group across multiple states. And there's new studies opening at North Shore, both looking at blood biomarkers for pancreatic neuroendocrine tumours and also looking at new PET scans just to see whether we can do it better. Oops, sorry. So, the conclusion, pop quiz. Anyone fallen asleep? No, good. What building is this? You're not allowed to answer if you've been there. Anyone? Hint? It's in a certain city in Spain. Sorry? Yep, Sagrada Familia. Good. So the reason I do neuroendocrine research is partly to enjoy going to Barcelona every year, except for this year and probably next year. Partly because of the wonderful people involved, but partly because people with this disease are really neglected. You know, no genomic analyses, no funding, uncertain future, poor education sometimes, like highly motivated patient group, but little in the way of publicly available information. So hopefully over the next few years we can continue improving that for our patients. Recently under Nick, our other people's leadership, we've been accredited as a Centre of Excellence for Neuroendocrine Tumours, so that will hopefully cement our lead in New South Wales in terms of driving this research in patient care. And a lot of people come together to make this happen. So all the people who are named there, particularly thanks to Alice, my research assistant, who has to put up with me 2.5 days a week, so thanks very much, and the international collaborators as well, and the funding on the bottom left, so Sydney Vital over quite a few years, NHMRC and the University of Sydney. So thanks for your attention, happy to take questions.